the trachea, so we're talking about the skeleton of the larynx, the muscles, the innervation, the mucosa, the internal structure of the larynx. And then we'll be talking about the trachea in the second part of the lecture. Okay, so we'll first cover larynx, everything about larynx, and then we'll go into the trachea. And then obviously you have to do the neurovascular supply. So the nerves and the vessels, okay, what supplies, what vessels, what arteries supplies the larynx, what nerve supplies it. Okay, we're talking about sensory innervation, motor innervation. So these are quite important. And then also, as well, of course, to talk about the clinical correlations, certain subjects, certain clinical conditions that are related to the larynx and trachea that we're going to talk about today. Okay, so this is a schematic diagram of what the larynx and trachea is. So you've covered this part here in the previous lecture, the nasal cavity, and then you go into the nasal pharynx. Okay, so pharynx are just the part of the tract that would connect the nasal cavity, oral cavity, to the larynx and the esophagus behind this laryngopharynx. All right, so at this level, okay, this is more respiratory tract. Okay, and then so this is also part of the respiratory tract, but this here, the oral cavity and the oropharynx are a little bit, they could be respiratory, but also gastrointestinal tract as well, related with the digestive system. Okay, but at the here, it will divide into the posterior part, which will go into the esophagus, will be more of part of GI tract, and then the anterior part here, which will go into the trachea and into the lungs, will be part of the respiratory tract. So this is a structure that we're going to talk. Okay, it connects with the right, and it will divide to go into the respiratory tract and the GI tract behind it. Okay, so the larynx here that we're talking about, this larynx here is definitely part of the respiratory tract. It's not involved in the digestive tract. So this is located in the neck. It's part of the cervical viscera in your cervical region. Okay, so what are the main functions of this larynx here? One is it would root air into the respiratory tract. It will stop the food coming into the respiratory tract. So it has a way to seal off your airway temporarily. Obviously, you can't seal it off forever because you need to breathe, but it can seal off at certain times when you need to ensure that the food bolus doesn't go into respiratory tract, say when you're swallowing. Okay, so the larynx help to guard your respiratory tract. Okay? Other than that, the larynx is also important for phonation, for producing voice. So larynx is sometimes it's known as your voice box. All right, so the larynx produces phonation. Okay, we've talked about that. Now this is the bit that you have to know about the larynx. So this is the anatomy wise. Okay, you have to know the skeleton, the cavity, the muscles, and the neurovascular supply to the larynx. Right. So let's just have a look where the larynx is. So you can see that it would be located. This is the whole neck here. That's your vertebra. So this is your posterior part of the body. That's the anterior part of the neck. It's located in the anterior part of the neck. If someone has the mic on. Hello? Okay. So it's located on the anterior part of the neck here. And you can see that it starts from about the level of C3, cervical vertebra C3 to C6. So this whole thing here is the larynx. All right. So you can start from the top here all the way to the bottom. Okay. So this is your larynx. And behind here would be the laryngopharynx. And down here would be the esophagus. Doctor? So this is your trachea. So behind here is your, hello? Yes? Yes?
Your slide has not changed. It's still on slide 4 right now.
Can you hear me?
I can hear you, but the slide has not changed.
Is there a problem?
Yeah,
Hello? No? okay? Everybody okay?
Are you still on slide 4,
Do
doctor?
you see the cross
Oh,
section of the
yeah.
head and neck?
It just changed right
I'm at
now.
the cross section of the head and neck. Do you see the same thing?
Yes, I can see now. Thank you, doctor.
Oh,
Doctor, we couldn't see earlier when you were explaining.
okay. Let me just move this part there to see if I can get. Can you all hear me? Hello?
Yes, yes, yes.
Can people hear me?
Yes, doctor, we can hear you.
Yes.
Hello? Can everybody hear me?
Yes, doctor, we can hear you.
Yes. So if I still get this like poor quality network. Ah. All right, let's try this one more time. Can you all hear me?
Yes.
Yes, okay.
Okay, let me just share my try to see. Can everybody see the cross section of the head and neck?
Yes.
Okay, perfect. Okay, so as we were saying just now, your larynx is located at the anterior part of the neck. So it's at the level of the cervical vertebra C3 to C6. So this whole thing here is the larynx, okay? So you can see later we'll look at what the larynx look internally, the skeleton of the larynx, and you can make sense of this whole area here. Okay, so anteriorly it'll be part of the respiratory tract, it'll go into the trachea, and posteriorly is where it'll go into the digestive tract, which will lead to the esophagus. But more superiorly, they have a common shared origin, especially in your oropharynx area. Okay, so this is a schematic diagram that we saw just now. So basically, it connects the oropharynx to your trachea. All right, and if we were to look at it from a posterior view, so this is a posterior view. Basically, these muscles here were all connected to each other. And what we do is we did a midline cut from the posterior and open up this muscle. Okay, so this on the right side, this on the left side. And now you can see the larynx from the posterior part. Okay, any idea what this is?
Doctor, your slide hasn't changed to posterior view.
Hello? Any idea what this structure is?
Doctor,
My
your slide has not
slide
changed.
hasn't changed to posterior view. Oh my goodness. Okay. Do you see it now? Hopefully
Not yet, doctor.
not yet. Well, I'm connected to my. It doesn't say bad connection anymore.
Doctor, maybe try to unshare and share again.
Okay, let's just do that. Hold on a second. Back to your stop sharing. Open share tray. Wait, let me just I'll come back in a while. Okay, how about now? Can you see it?
Yes, doctor.
Okay,
Yes,
so
doctor.
this is the right. So this is a posterior view of the larynx. Okay, so basically these muscles here are all interconnected. Okay, it forms like a tube, but we've cut this muscle and we've opened it up to look internally. Okay, and this is the part. This is the larynx here that we're going to talk about. This here at the back is your laryngo pharynx. Okay, so all of this at the usually it's the oropharynx, but this one specifically this is the larynx, right? This here, as you can see, that's your nasal cavity. Can you see the turbinates? Okay, this is your turbinates. Okay, and this anterior to this is your oral cavity. That's actually your tongue. That's the root of the tongue here. So from there, you go into the larynx anteriorly and posteriorly would be the laryngopharynx. All right, so this is the structure that we want to see in a more detailed manner, right? So if we were to take your larynx out, okay, so we were to take it out from the body, this is what it looks like. Okay, so this is the larynx without the musculature. Okay, you don't have any muscles. What we usually, you don't have any muscles. We've taken out the muscles. You know it as the skeleton. So this is your laryngeal skeleton here. Okay, and we're going to talk about this in detail. All right. So as I mentioned earlier, your larynx is used to guard the air passages, okay, the airway, when you're swallowing, when you're doing deglutition, and also it helps to uh, uh, what do you call it? It helps in phonation, okay, in voice production. All right. So in the laryngeal skeleton, you have mostly made out of cartilages, but you also have ligaments and membranes and joints to hold it together. So cartilages, you have 9 in total, of which is you have 3 single cartilages, all right, and then you have 3 paired cartilages. So these 3 paired cartilages you count as 2, so 2, 4, 6, 7, 8, 9. All in total, you have 9 cartilages, right? The ones that occur singly, as you would expect, it would be in the midline, and the one that occurs that in pairs, they're smaller, and you have it on the left side and on the look at the laryngeal skeleton here. The hyoid bone is not technically part of the larynx, but usually you would draw it together because there's a lot of muscles that are connected from the larynx to the hyoid bone itself. Okay, so this here is the hyoid bone. Whenever you have a bony structure, they usually color it more of a yellower hue. All right, this here at the back here would be your laryngeal skeleton. So the 3 cartilages that occur singly. Okay, you have this is the epiglottis. All right, the one at the back here. If you look from the posterior view, it is clearer. Okay, in view, it's a leaf-shaped cartilage. So the epiglottis would help to close the airway. Okay, but we'll talk about that later. And the midline here, that's quite big here. This is your thyroid cartilage. The thyroid cartilage looks like a little bit like a shield, okay, because it covers only the anterior part. Posteriorly, there's nothing covering the thyroid cartilage. Okay, so that's the thyroid cartilage. And then underneath the thyroid cartilage, you have this circular-like structure. Okay, so it forms a complete circle, and this is your cricoid cartilage. So the 3 cartilages that occur singly is your epiglottis, your thyroid cartilage, and also the cricoid cartilage. And if we're to look at the paired cartilages, like I mentioned, paired cartilages, they are smaller. Okay, so you have here, this is the arytenoid. All right, so you have the arytenoid sitting on the cricoid cartilage, and above the arytenoid, you actually have 2 small cartilages. It's known as the corniculate. So corniculate sits on top of the arytenoid. All right, so this cartilage that sits on top of the cricoid here, it looks sort of like a triangular structure, sort of like an A, so you call it arytenoid. Above that would be the corniculate, and then above that you have the cuneiform. All right, so let's look at these cartilages in as the skeleton. Okay, so we'll just have a view of how it is arranged. All right, as I mentioned, that's your thyroid cartilage, okay, from the anterior view. That's your thyroid cartilage from the posterior view. And this is your thyroid cartilage when you have a sagittal section. Okay, on top of your thyroid cartilage, you have the epiglottis, leaf-shaped cartilage. Okay, you can't miss it. That's the epiglottis. And then underneath your thyroid, you have the cricoid. Okay, so cricoid, it is a circular structure. Okay, so it's a full circle. All right, and above the cricoid, you have the arytenoid. Okay, arytenoid, and above the arytenoid, you have the corniculate, and then suspended in soft tissue, you have the cuneiform. All right, so let's have a look at the whole structure, the cartilages in one by one. Okay, so that's your thyroid cartilage there, mentioned earlier. Here you have a sagittal section. That's what it looks like. So you've cut at the midline. Okay, and if you were to look at it from the outside, this is what it looks like. So you can see that the thyroid cartilage has this projection. Okay, 2 that goes superiorly and 2 that goes inferiorly. So this is known as the horns, right? So you have a superior horn, and you have you have 2 inferior horns, right? So the inferior horn, you can see, is actually articulating with the cricoid cartilage underneath here. So when we're talking about joints later, this is part of the joint of the larynx, right? It's between the thyroid cartilage here, the inferior horn of the thyroid cartilage, along with your cricoid cartilage. Right, other than the horns, what you have this big structure here. This big structure here is known as the lamina, Lamina. All right, so you have a left lamina and you have a right lamina. So these two laminae will meet together at the anterior part of the neck. Okay, so you'll meet together at the anterior part and at the midline, right? And this where it meets here, where it meets the two laminae meets each other, you find that you have this prominence. Okay, you have this structure here of the two laminae when the two laminae meet each other. So this is called the laryngeal prominence, right? Laryngeal prominence. Any guesses as to in which gender the laryngeal prominence is more prominent, is more significant?
In males.
In men. Okay, so laryngeal prominence is, if in layman's term, is the Adam's apple, so it forms the Adam's apple. So in male, the angle is more acute than in female, so that's why it's more prominent in males. All right, so there are certain there are certain procedures as when a person a male wants to change his gender to female, they would actually shave off this laryngeal prominence so that it gives a less significant appearance. Okay, so that's how you actually can make your Adam's apple less prominent. Just a side note. Okay, so again, laminae, left and right laminae meet together in the midline. Okay, at the superior part here, it forms the laryngeal prominence. You know it as your Adam's apple, so it's quite superficial because you can actually see it. Not only can you palpate it, you can see it. All right, and then at the bottom, at the posterior part here, you have two superior horns and you have two inferior horns. So that's basically your thyroid cartilage. All right, this is just to highlight where the thyroid cartilage location is when you look at it from the posterior view. Okay, so we talked about all this, and now we're going to look at the cricoid cartilage. This this notes, rather, you can read on your own later. I'll just explain to you through the pictures. Right, if you to your thyroid cartilage, you have the cricoid cartilage. So cricoid cartilage is a full, complete ring. Okay, so if you were to palpate your neck from the anterior, okay, the only structure that can compress the esophagus posteriorly, the only structure of the larynx is your cricoid cartilage because it's a full ring. Okay, so it's narrower in front and it's wider at the back. This is the posterior view. So you can see that posteriorly, the ring is wider. Okay, it looks like a signet ring. Okay, you have a narrow band and a bigger part like the signet ring. Okay, so this anterior part here is called the arch. Okay, the narrow part here is called the arch, and posteriorly here, this is called the lamina. So you only have one lamina in the cricoid cartilage. As like the thyroid cartilage, these two are hyaline cartilage. Okay, so you can still remember what hyaline cartilage look like in histology section. Okay, so then you can know what the hyaline structure of the cricoid cartilage looks like. Okay, that is again your cricoid cartilage, narrower anteriorly and broader posteriorly. The arytenoid sits nicely on your cricoid cartilage, and it also is involved in a joint with the thyroid cartilage here, with the inferior horn of your thyroid cartilage. Okay, next up, we'll be talking about the paired cartilages. So on top of the cricoid cartilage, you have the arytenoid cartilage. So arytenoid cartilage, as I mentioned previously, it has like a little triangular-like or pyramidal-like shape. Okay. It sits on your cricoid cartilage, and you have three projections that's important for your function of your larynx. Okay, so the projection that goes superiorly, this is your apex. So you can imagine that the cricoid cartilage would sit inferior to this. Okay, so this here on the projecting superiorly is your apex. Okay, the one that projecting in anteriorly, going to the front, this is your vocal process. So vocal process here, later when we're talking about ligaments, it would hold the vocal ligament. Okay, and then this here, this projection, this actually does not go posteriorly, it goes laterally. This is a lateral projection. Okay, this lateral projection here is called the muscular process, right? So that's why you can't see it on this side, because it's on the opposite side on the medial surface, on the lateral surface. It's a lateral projection, so it's called the muscular process. And by its name, you can imagine that there will be a lot of muscles that would be attached to this muscular process. And later on, we'll be talking about which muscle that is. Okay. Right. Next, cartilages. Okay, that sits on top of your arytenoid here. This here is your corniculate. Okay, and then the one that the cuneiform actually does not have any attachment because it's suspended in the fold. Later we'll be looking at it's suspended in the soft tissue. We're looking at that when we're talking about the ligaments and membranes. Okay, so that's corniculate sitting on top of the arytenoid, and then you have the cuneiform. Okay, so that is all the paired cartilages. Okay, so as I mentioned, corniculate, epiphysis or arytenoid, and cuneiform is no direct attachment, but it'll be located in the folds. We'll be looking at that later. And then lastly is your epiglottic cartilage or your epiglottis. So epiglottis is a leaf-shaped like cartilage, and it's the only cartilage in your laryngeal skeleton that is made up of elastic tissue. So it's an elastic type of cartilage. I hope you still remember your different kinds of cartilages. You have hyaline, elastic. Okay, so the epiglottis is an elastic type of cartilage, and it helps to cover the larynx when deglutition occur. Okay, so the epiglottic cartilage here, the epiglottis, actually is located behind the tongue, okay, behind the root of the tongue. So if we were to have a picture of the tongue here, all right, this is the posterior part of the tongue. You can see that this is the outline of the epiglottis. Okay, so as it attached to the root of the tongue, this attachment here, this is known as a glossoepiglottic fold. When you see the word glosso, okay, glossal, it comes from the root word glosso, it would be in relation to the tongue. Okay, so that's your glossoepiglottic fold. And on either side of the glossoepiglottic fold here, you have what is known as vallecula. Okay, so that's important in certain clinical practices that you want to do, clinical procedures. The vallecula is important. Later we'll be talking about that. Okay, so far okay with the laryngeal skeleton, with the cartilages. Any questions? No questions. So there's going to be a lot of pictures that I put up in the slides that I'm going to share with you later. So hopefully you can have a look at that and help to make it easier to digest all these new terms that you have to know. All right, so we've talked about the skeleton, we've talked about the cartilages. Now you need to know about the membranes and ligaments. All right, so exterior membranes, you actually have 6 in total. The 3 that you can see clearly from anterior view. So this is anterior view again. If we need to go over, this is your thyroid cartilage. This is your cricoid cartilage. So above here, sitting on top of your cricoid, okay, that you can't see from anterior view, you can only see from posterior view, would be your arytenoid. Okay, so the ligaments that you can see here, this big ligament here that connects the thyroid cartilage to the hyoid bone, this is your thyrohyoid membrane. Okay, so there's a thyrohyoid membrane, and then connecting your thyroid to the cricoid, this is your cricothyroid ligament. Okay, by cricothyroid ligament, you can see in the midline you have a thickening. So this is known as the median cricothyroid ligament, and on its side is the lateral cricothyroid ligament. Okay, and lastly, that connects the cricoid to the first tracheal cartilage. underneath here is known as your cricotracheal ligament. So these are the structures that you can see clearly from anterior view. Okay, so thyrohyoid ligament, thyrohyoid membrane. Sorry, if it's slightly bigger, it's more of a like a flat-like structure, and it's quite wide. You usually call it membrane. And ligaments, they're more like cord-like structures. Okay, in terms of the larynx, so you call it ligaments, but they're essentially the same tissue. Right, so if you were to look at the thyrohyoid membrane here, you can see there's actually a little hole at the side here. So this little hole here allows neurovascular structures to go inside into the larynx. Okay, later when we talk about the neurovascular supply, you can see that there's a certain vessel and also a certain nerve that would pierce the thyrohyoid membrane to supply the inside of the larynx. Okay, so that would be the ligaments and membranes that you can see from the anterior view. Okay, so if we were to look at so if we were to look at the other three ligaments, okay, that you can see if we remove the thyroid membrane here, so we remove the thyroid cartilage, the thyroid cartilage that we've removed, you can see more from the posterior view or from a sagittal section, right? You have these three ligaments. Number one is your hyoepiglottic ligament. So this would attach the hyoid bone to the epiglottis. And then you have your thyroepiglottic ligament that would attach the thyroid cartilage to the the thyroid cartilage to the epiglottis. It is a lot of things is you look at the attachment, what attaches what, and you can name the ligament. Okay. The other one is the aryepiglottic ligament. So aryepiglottic ligament here is actually, it is located here from the epiglottis to the arytenoid. Okay, so aryepiglottic ligament. What's important about this aryepiglottic ligament is that it's part of a membrane. Again, like I mentioned, membrane, usually they're white and flat-like structure. Okay, this is a membrane here that's been cut, right? But the posterior end here, or rather the superior margin here, it forms, like, it has a little bit of a thickening, and it forms this aryepiglottic ligament. Okay, so aryepiglottic ligament is here, all right? But this whole structure here is a membrane. So this is known as a quadrangular membrane. But the superior margin, the superior free margin here, has a thickening, and is known as the aryepiglottic ligament. Okay, so you always have to remember that aryepiglottic ligament is the superior free margin of the quadrangular membrane. Right, any questions about the ligaments? Okay, again, let's go over again the 6 ligaments that you can see. From anterior first, you have the thyrohyoid membrane. Okay, you have the median cricothyroid ligament and the cricotracheal ligament. And then if you were to do a sagittal section, you can see the hyoepiglottic ligament, the thyroepiglottic ligament, and the aryepiglottic ligament, okay, which is the superior free margin of your quadrangular membrane. Now we're going to talk about that quadrangular membrane that we've mentioned earlier. So quadrangular membrane, it is kind of membrane. Sorry, let me just move on here. Okay, so we've talked the intrinsic type of membrane and ligaments. You have 2. Okay, so this here is your quadrangular membrane, and this here is your cricothyroid ligament. Okay, so this external side, you only have 2 that you need to know. All right, so quadrangular membrane, you can see that it goes all the way from epiglottis. Okay, so it goes all the way to the corniculate and the arytenoid, and then it'll go back to the epiglottis. Okay, so this whole thing here is your quadrangular membrane. It forms sort of like a quadrangular shape, so it's known as quadrangular membrane. Superior free border, we've talked about just now, is your aryepiglottic ligament. Inferior free border here is known as your vestibular ligament. So this is quite important, yeah. quadrangular membrane is quite important in the sense that it has two free borders, one on the superior part and one on the inferior part. So superior part, just now we've talked about it as the epiglottic ligament, and inferior part here is known as the vestibular ligament. Okay. And then on the inferior side here, we have the cricothyroid ligament. Okay, so cricothyroid ligament is also a ligament on the inferior part. And in certain books, sometimes you don't find the word cricothyroid ligament. What you find is cricovocal. Okay, and sometimes it's known as cricovocal, and sometimes it's known as cricothyroid. Wait, no, conus elasticus is the same thing. Okay, so this is going to be referring to the same structure. Okay, usually I would call it cricothyroid because it attaches the cricoid to the thyroid cartilage, so cricothyroid. But sometimes people call it cricovocal, and sometimes people call it conus elasticus. So as the name suggests, it connects the cricoid to the thyroid cartilage, and the cricothyroid here, okay, on the superior part here, you have a superior free margin. So the superior free margin here is known as the vocal ligament. Okay, so the quadrangular is the vestibular ligament. The cricothyroid is the vocal ligament, the superior free margin. Okay, so far okay, everybody? Any doubts that you have at the moment? Everybody's okay? Hello?
Yes, Dr.
Yes?
I
Yap.
think you're okay.
Okay, so far okay. Yeah? It's a little bit complicated, but I think if you were to look at a lot of pictures, you can make sense of it. All right, okay, so the ligaments here, if you were to look from superior, which is how we usually can only look at these structures in living people, we can only look from superior because that's where the respiratory tract is. We can't look from anterior, we can't look from posterior because that's the neck. Okay, unless you cut through skin, you cut through all these cartilages, the only way to view the structures is through the superior part here where you put a scope in. Okay, so when you look from superior, this is what you would see. Shouldn't have done all this. Okay. Oh. Okay, this is how you would see it. All right, so this is obviously in living people you would have mucosa folds over it. So you have like on the outside you have skin, on the inside all of your structures is going to be lined by mucosa, right? But this is the skeleton of it, right? You can see these this here that's redder in color, the one with red issue. This is your quadrangular membrane, okay? And the one underneath that, the one in a lighter beigey kind of color, this is your cricothyroid ligament, okay? So the the quadrangular membrane here, the inferior free border just now is known as your vestibular ligament. And for the cricothyroid ligament, the superior border is known as your vocal ligament. So these structures, you can see that it actually comes close to the midline. But the vocal ligament comes closer together than the vestibular ligament. So if you look from superior, you can see both because the superior one here is more abducted, is more lateral, whereas the more inferior ligament, the vocal ligament, is more in the midline. So you can actually see these structures. Okay, right. Okay, just to go over the joints, okay, you have two kinds of joint. You have the cricothyroid joints and the cricoarytenoid joints. Actually, I've talked about this now. So the cricothyroid joint here would connect the inferior horn of your thyroid cartilage to the cricoid cartilage. Okay, it's a synovial kind of joint. Okay, so when muscles act on this joint, you can actually move your thyroid cartilage forward and it will tilt downward. So all of this will be making the vocal ligament either stretch or relax a little bit. Okay. Right. Other than that, you also have the cricoarytenoid joint. So cricoarytenoid joint is between the cricoid cartilage and the arytenoid. So you can see that the arytenoid can actually swivel. Okay, it can swivel to laterally and posteriorly. Okay, and you can go to the midline as well. So what it does is that when this moves, your vocal ligament is going to be abducted or adducted. Okay, it will move away from each other or near each other. So a lot of these movements of the joint and the muscles will affect your vocal ligament. Okay, either the vocal ligament will tense or the vocal ligament will be relaxed, or you can also put your vocal ligament closer together or your vocal ligaments away from each other. So by moving your vocal ligaments, you can actually affect the kind of voice that you make, okay, the phonation that you have, the tone, the pitch of your vocal ligament. So vocal ligament is very important, as the name suggests. It's a vocal ligament, so it's very important in vocalization. Right. Now let's look at the larynx as it's being covered by mucosa. So we've talked about the skeleton just now. That's your thyroid cartilage here. That's your cricoid cartilage here. Okay, that's your hyoid bone. All right. Here would be the quadrangular membrane. Down here would be the conus elasticus or your cricothyroid ligament. Okay. So remember, inferior free border of your quadrangular membrane is your vestibular fold. Superior free border of your cricothyroid ligament is the vocal ligament. So all of these structures here, this is your epiglottis, all right? So all of these structures here will be lined by mucosa. Again, on the outside, all your structures is lined by skin. On the inside, it'll be lined by mucosa, okay? So when you have this mucosa covers all these ligaments, okay, immediately the ligaments will be known as folds, okay? So your vestibular ligament is going to be known as vestibular fold. Once it's covered by mucosa, your vocal ligament here will be known as vocal fold. Okay, once the ligament is covered by mucosa. Okay, so the cavity of your larynx runs all the way from the laryngeal inlet. Okay, this is the laryngeal inlet. Later we'll be looking at it in a more specific manner to describe all the structures that form the laryngeal inlet. And we'll go all the way to the inferior border of your cricoid. Okay, so that's basically where your larynx starts and where your larynx ends. Okay, from the laryngeal inlet all the way to the inferior border of your cricoid cartilage. Because remember, the inferior to your cricoid cartilage will already be the first tracheal ring. So that is where the trachea will then begin. All right. So what is laryngeal inlet? Right. This is a picture of the laryngeal inlet. Okay. The whole thing here is called the laryngeal inlet. So it forms the opening of the larynx, the opening to the internal part of the larynx, the cavity of the larynx. Right. So the laryngeal inlet anteriorly, it's being made up of the epiglottis, or if you want to be more specific, the mucosa that covers the epiglottis. Okay, so lateral here would be the aryepiglottic folds. Remember, the superior part, the superior free border of your quadrangular membrane is known as aryepiglottic ligament. So once it's being covered by mucosa, it's the aryepiglottic fold. Okay, so that's your aryepiglottic fold here. And posteriorly, here in between the two arytenoid cartilage here, between the two arytenoid cartilage is your interarytenoid notch. So all of this forms your laryngeal inlet. Okay, your epiglottis, your aryepiglottic fold, and the interarytenoid notch. So again, this is the opening to the cavity of the larynx. Okay, so the larynx the cavity can be divided into three. I don't know why I did all this animation. Okay, so the larynx, if you were to look at it, you can actually divide it into three, so it's more easier to describe it. And what divides your larynx is these two folds here. The vestibular fold, which is inferior border of your quadrangular membrane, and the vocal fold, which is the superior border of the cricothyroid ligament. Cricothyroid ligament. Right, so I'm going to repeat it a lot of times because it's an important structure that you have to know when you talk about the larynx. Okay, so these two folds here will divide the larynx into three parts. Okay, superior to the vestibular fold, okay, superior to the inferior border of your quadrangular membrane. This here you can part number 1, which you call it the laryngeal vestibule. Okay, inferior to your vocal fold is part number 3, where we call it the infraglottic cavity. And then in between the two folds here, in between the vestibular fold and the vocal fold here, you know it as the, can call it part number 2. Okay, this part here, the middle part, because we are very creative like that. Okay, it's known as the middle part. All right, so the laryngeal vestibule, okay, so it starts all the way from the laryngeal inlet, because laryngeal inlet is the beginning of the whole cavity of the larynx anyway. So it starts from the laryngeal inlet all the way to the vestibular fold. Okay, not much structure to talk about there. So you have some mucosa that lines it, and the side wall will be made up of your quadrangular membrane. Okay, and then if you go to the middle part, you can see that it's going to be in between the two folds, in between the vestibular fold and the vocal fold. Okay, and this middle part here, okay, you have a little projection to the lateral side. Okay, in between the two folds here, the mucosa actually projects laterally. Okay, to give you this sort of like a sinus, a blind pouch here. Okay, on the lateral side. And this blind pouch here is known as the laryngeal ventricle. Okay, this here is the laryngeal ventricle here. Okay, if you were to just color it in, that's your laryngeal ventricle. And it doesn't end there. If you were to look at the lateral projection here, you can see a little bit of the outline. It actually also projects anteriorly, the middle part. So if I were to just show you this picture here, okay, so that's the laryngeal ventricle where it projects laterally, but it also has a projection anteriorly. So you can see that the ventricle also goes anteriorly as far as the thyroid cartilage. So this here is your laryngeal saccule. The one that projects laterally is known as ventricle, and from there you have a projection that goes anteriorly, that's known as the laryngeal saccule. So these are all parts of the middle part of the cavity of the larynx, right? So the middle part again is in between the vestibular fold and the vocal fold. So inferior to your vocal fold, okay, inferior to this, all of this here until your cricoid, inferior border of your cricoid cartilage is known as the infraglottic cavity. Okay. Now, why is it important for us to divide the cavity of the larynx is to give more organization. So it's easy when you want to talk about certain structures in your cavity of the larynx. So you have like divisions, making it easier to when you want to name certain structures. Okay, where is it location? How is it related to certain structures of your larynx? Also, it's important because you have different innovation. Okay, so mucosa is all about sensory innovation. So you have different innovation between different parts of the larynx. We're going to talk that when we talk about the neurovascular supply. Okay, so now the folds, the vocal fold and the vestibular fold. Okay, so the vocal fold that we need to also be mindful of. The again, vocal fold here is the superior border of the cricothyroid ligament. Okay, so the vocal fold is known as a true vocal cords. Okay, sometimes when you talk about vocal cords, it also is another name for your vocal fold. But the vocal cords or the vocal fold, apart from it having just the mucosa overlying the vocal ligament, you also have a slip or muscle called the vocalis muscle. So the vocalis muscle and the vocal ligament, along with the mucosa that covers it, will form the true vocal cord or the vocal fold. All right, and superior to that, as you already know, is the vestibular fold. Okay, so vestibular fold, you have the vestibular ligament with the mucosa overlying it. Right, sometimes they call it the false vocal cord. Okay, so yeah, you have the false vocal cord, which is your vestibular fold, and then you have the true vocal cord, which is your vocal fold, along with the vocal, which consists of the vocal ligament and the vocalis muscle. Okay, now as I mentioned earlier, when you look at the larynx from superior, Here you can see these two ligaments, these two folds. Okay, this is covered by mucosa. So to see these two folds, actually you can see this picture here. So this picture here is if you do a scope of the larynx, okay, a laryngoscope, you can see these structures here. Okay, so that's anterior. This is the anterior part, and this is the posterior part. Okay, you can see anteriorly, that would be the epiglottis. Okay, so if you actually trace this, all of it, epiglottis, all of this here is actually the laryngeal inlet. Okay, laryngeal inlet again, epiglottis anteriorly, laterally would be the aryepiglottic fold, and then interarytenoid notch. Okay, and this bumps here is actually your corniculate and cuneiform ligaments. You remember, cuneiform does not have any attachment. Cuneiform will only be embedded in the aryepiglottic fold here, which forms part of the laryngeal inlet. That's your cuneiform. The corniculate, because it sits on top of your arytenoid, it also will be part of your laryngeal inlet, because this whole thing is your aryepiglottic fold from the arytenoid to the epiglottis. Right? So if you were to look at a scope picture, you can identify structures actually. So epiglottis anteriorly, aryepiglottic fold, and then you see the cuneiform tubercle, the corniculate tubercle. And then this one here, this line here, I highlight it in red. This is the vestibular fold. Okay, remember the superior fold is more abducted. Okay, and the inferior fold, which is your vocal fold, they're more adducted. So you can definitely see the vocal fold. Okay, now what is rima? So rima vestibuli means the space between the two vestibular folds. So you have the left vestibular fold and the right vestibular fold. The space between it here is called the rima vestibuli. Okay, so rima vestibuli is the entrance to middle part or middle chamber of your laryngeal cavity. And then if you were to look underneath here, you can see the vocal fold. So the vocal fold, the space between the vocal fold is known as your rima glottidis. The rima glottidis in between the two vocal folds, it will be the entrance to the infraglottic cavity. So anything above the rima glottidis is the middle chamber or middle part. Anything inferior to rima glottidis is the infraglottic cavity. Okay, and this is how we can actually view your vocal cords. Okay, whenever you do a scope, people say that sometimes you can have like nodules on the vocal cords. Okay, that especially if you sing a lot, if you use your voice a lot, all right, you can actually irritate the vocal fold. All right, and to be able to see it, to be able to visualize these pathological structures, is you have to do a scope. Okay, direct view. All right, okay. So your rima glottidis here, actually, because it's made out of your vocal fold, it can be brought nearer to each other and can be brought further from each other, because your arytenoid can move. Remember the arytenoid just now, when it pivots, it can bring the vocal fold together, it can bring the vocal fold apart. So rima glottidis can have various shapes depending on what you do. Okay, so usually if it's like okay, if you're just breathing normally, it would look like a wedge kind of shape. If you are, out of breath, if you do a lot of exercise and you have to do forced respiration, then it will be more abducted. Okay, it will be further away from each other. So the rima glottidis has this kite shape, kite-like shape to it. So to allow more air to move in and out of your respiratory tract. And then if you have the vocal fold bring closer to each other, so the rima glottidis has this slit-like effect, so slit-like shape. This is when you're talking. Okay, so when you're talking, you need to have the air hit the vocal fold. Okay, so when the air vibrates, it hits the vocal fold, then you only you can produce sound. Then you have phonation. Okay, so far. Any issues with the skeleton of the larynx and also the cavity of the larynx? No problem. Are we still around or have we all gone?
So far it's okay.
So far, okay, yeah, Jonathan. Would you like a break or are you willing to soldier on?
I think we can go on.
You think you can go on? Okay. So we just have to talk about the muscles and the neurovascular supply of the larynx before we move on to trachea. But trachea is gonna not be long. Okay, the bulk of the lecture is on the larynx. All right. Larynx is a more complicated structure because it involves information. So we have like this more higher order functions. They are more complicated. Okay, right. So when we talk about the muscle for the larynx, you have extrinsic muscle or you have intrinsic muscle. Okay, so same as your ligaments and membranes, you have external and internal. This one you have extrinsic and intrinsic, which basically means the same thing. So the extrinsic muscle are the ones that you've actually gone through in your musculoskeletal system. Okay, so you have your suprahyoid muscles and infrahyoid muscles. So basically, they work together to either elevate the hyoid and therefore the larynx, or it will depress the hyoid and the larynx. So suprahyoid, infrahyoid. So infrahyoid are your strap muscles. Hope you can still remember. Suprahyoid, you have four. Okay, you have stylohyoid, digastric, mylohyoid, and geniohyoid. So a little bit of a revision. Okay, so this muscle here that has two portions. This is your digastric, the anterior belly, and the posterior belly of your digastric, right? And then from the styloid process to the hyoid bone, that's your stylohyoid muscle. Okay, from the mandible to the hyoid bone, you have your mylohyoid, and also in the midline from the mandible to the hyoid bone is your geniohyoid. So all of this here occur superior to your hyoid bone, so you call it the suprahyoid muscle. And what it does, it elevates the hyoid bone, and because the larynx is connected to your hyoid bone, so it also elevates the larynx. And then the infrahyoid muscles are also known as your strap muscles. You actually also have four. More superficially, you have this muscle here. This is your um, omohyoid muscle. Okay, and then this here would be the stenohyoid. So if we take these two off, you can see the thyrohyoid and the sternothyroid muscle. So all of this is located inferior to your hyoid bone. Therefore, they're known as the depressors of your hyoid or the infrahyoid, okay, which means underneath your hyoid bone. So pretty easy, all right. The intrinsic muscle is a little bit more complicated. Okay, there are 7 intrinsic muscles that you have to know, and it moves the laryngeal part. So it moves the most often than not, it will move your arytenoid cartilage. Okay, it swivels it, it pivots it so that it allows your vocal fold to be abducted or adducted. Okay, in terms of the vocalis or the one that moves the cricothyroid joint, that would adjust the length and tension of the vocal fold. All right, so when you do this, you can produce a range of sounds. Okay, so these are the muscles that you have. You have 7 muscles altogether, right? Um, oblique arytenoid, thyroepiglottic, posterior, lateral cricoarytenoid, transverse arytenoid, cricothyroid, and vocalis muscle. Okay, it's quite a handful to know. We'll go very briefly over it, but at the end of it, I will give you a table for you to see. I think it's most important to know the certain muscles that have very peculiar things about it. Okay. All right. So oblique arytenoid. Oblique arytenoid, as the name suggests, so it will be located near your arytenoid. It will move your arytenoid cartilage, and it's known as oblique because it forms this X-like shape to the posterior of the arytenoid. So when it contracts, okay, it contracts the lateral part here. It will actually bring the vocal folds nearer to each other. So what it does, it narrows the inlet, the laryngeal inlet, okay, And then you have your thyroepiglottic. Thyroepiglottic will be on the inside, still an intrinsic muscle, but you can see it, it's on the side of your quadrangular membrane. So the thyroepiglottic here would help to widen the inlet, because when you stretch, it will bring the inlet further from each other. This here was your oblique arytenoid, okay? And this here would be your thyroarytenoid muscle. All right, posterior cricoarytenoid would be located here. So once you contract this muscle, you pull the muscular process, and it would swivel that way. Okay, so once it swivels this way, it will actually abduct the vocal fold. And what is important about the posterior cricoarytenoid muscle is the only muscle that will abduct your vocal fold. And why is it important to abduct the vocal fold is because if you don't abduct it, the vocal fold will come close to each other. Okay, sometimes it will even meet in the midline. And when you meet the vocal fold together in the midline, your rima glottidis is basically non-existent. Okay, so the air cannot move in and out of your respiratory tract. So if you're not able to abduct the vocal fold, you're actually not able to breathe. So that's why your posterior cricoarytenoid is very important. Okay, if you paralyze your posterior cricoarytenoid, you will not be able to breathe, and you can have what is known as stridor. Okay, so this is important in your clinical correlates. All right, the lateral cricoarytenoid meanwhile will adduct, so it brings the vocal fold closer to each other. And then you have the the transverse arytenoid, okay, which connects the two arytenoids together. And what it does, it will close the posterior part of the rima. The posterior part here, it will bring together, will adduct as well, basically. Okay, and then you have the cricothyroid. So cricothyroid is the only muscle that you can see from anterior view. Okay, so it's located on the outer part of your thyroid cartilage and your cricoid cartilage. So it's located on the outer part, and what it does, it will bring your cricothyroid joint. It will move your cricothyroid joint. So it will bring your thyroid cartilage forward and downward. Okay, so bring your thyroid cartilage that way when it contracts, and it's located on the external side of your cricoid and thyroid cartilage. Okay, because of the location, is the only muscle that's not being it has a different innervation than the other muscles, internal muscles of your larynx. So cricothyroid here is innervated by your external laryngeal nerve, because it's located on the outer part of the thyroid cartilage and the cricoid cartilage. And lastly, is a muscle that we've looked at just now, is your vocalis muscle. Remember the vocalis muscle, along with your vocal ligaments and the mucosa that covers them, they're all part of your vocal fold. So vocalis muscle tenses your vocal cord. Okay, so you can change the pitch of your voice. Okay, so these are the summary of all the muscles that you have. So cricothyroid is important because it has a different innervation than the rest of the other internal muscle, intrinsic muscle. Okay, cricothyroid is the only muscle that is innervated by the external laryngeal nerve. The other muscles here are innervated by your recurrent laryngeal nerve. Okay, more specifically the inferior laryngeal nerve, which is a part of your recurrent laryngeal nerve. Okay, but the external laryngeal nerve here is different. It's part of the superior laryngeal nerve. We'll be looking at that later. And another muscle that is quite peculiar as well is your posterior cricoarytenoid, because it's the only muscle that abducts the vocal fold. So if the posterior cricoarytenoid is paralyzed, then you cannot abduct your vocal folds, and you cannot breathe. Okay, especially if you have this bilateral paralysis. Okay, that means your left and right part of your vocal fold cannot be brought apart. Okay, because if only one part, then it will be just hoarseness. You can still breathe, but both of it you cannot abduct. Then you have your stridor, and you won't be able to breathe, which makes it an emergency. All right, now we go into the neurovascular supply. Okay, so this is a whole overview of the neurovascular supply. Let's look at the nerves first. All right, so this is your vagus nerve. A lot of your larynx will be innervated. Well, I think almost all of your larynx will be innervated by the vagus nerve. So this here is your vagus nerve. That's part of the ganglion of the nerve. Okay, from the vagus nerve, uh, you have a branch coming off. So this branch here is the first important branch here. This here is known as the superior laryngeal nerve. Okay, superior laryngeal nerve is a branch of the vagus nerve. So superior laryngeal nerve coming, as the name suggests, from superiorly. Okay, it will divide into two. One will pierce the thyrohyoid membrane. Remember, your thyrohyoid membrane had an opening. Okay, so the thyrohyoid membrane has an opening where the branch of your superior laryngeal nerve will pierce and supply the inside of your larynx. So the branch that goes inside of the larynx is known as the internal laryngeal nerve. Okay, and the branch that continues outside of the larynx is the external laryngeal nerve. Okay, and if you can see here, this muscle here, that's your cricothyroid muscle. That's the only muscle, that's the only intrinsic muscle that's innervated by the external laryngeal nerve. You can see that it's located externally, so it will be innervated by the external laryngeal nerve. Okay, so that's the first nerve that's important, the superior laryngeal nerve. Again, it will divide into internal and external. So internal will go into the cavity of the larynx through the thyrohyoid membrane, and the external will go on the outside of the larynx, and it will also innervate your cricothyroid muscle. Okay, as the vagus nerve continues inferiorly, it will continue all the way down near the arch aorta. You can see that it will give off a branch here that goes back upwards. Okay, this here is your recurrent laryngeal nerve on the left that winds around the arch of aorta, and on the right side, it will just wind around your subclavian artery. It doesn't go as far inferiorly as the left side. Okay, as it goes winds around the right subclavian artery here, it again also gives off a nerve that goes back upwards. That's your recurrent laryngeal nerve. Okay, so recurrent laryngeal nerve and the superior laryngeal nerve. Okay, recurrent laryngeal nerve as it goes inside the larynx, it will have a branch known as the inferior laryngeal nerve. Okay, so this here is your recurrent laryngeal nerve. The terminal branch would be the inferior laryngeal nerve. Okay, laryngeal nerve. Right. So superior comes direct off of the vagus, but the inferior would be a branch of your recurrent laryngeal, the terminal branch of your recurrent laryngeal nerve. Okay, so for sensory innervation, okay, you have different innervation. As I mentioned, your cavity. Remember your cavity, you have the vestibule, okay, vestibule, and then you have the infraglottic cavity, and you have the middle part. Okay, and this is going to be divided by the vestibular fold and also the vocal fold. All right, so anything below the vocal fold, basically your infraglottic cavity will be innervated by the recurrent laryngeal nerve. So this here, the innervation of your infraglottic cavity will be the recurrent laryngeal nerve. Okay, or if you want, you can also say the inferior laryngeal nerve. Okay, anything above the vocal fold, which is basically your vestibule, okay, and your middle part or your middle cavity here will be innervated by, so these two will be innervated by the internal laryngeal nerve, which is a part of the superior laryngeal nerve. Okay, so innervation of larynx in terms of sensory, below vocal fold is by the recurrent laryngeal nerve. Above the vocal fold is by the internal laryngeal nerve. Okay, and motor innervation, recurrent laryngeal nerve will innervate all of the intrinsic muscles of larynx except the cricothyroid. because cricothyroid is, you can see it from the external side. Okay, so it's going to be innervated by the external laryngeal nerve, which is a branch of your superior laryngeal nerve. The other muscles will be a branch of the nerve that's coming from the inferior portion, which is the recurrent laryngeal nerve. So I hope you will remember that. Okay, in terms of blood supply, your innervation of the larynx would take blood supply from the thyroid. Okay, so if you can still remember, that's your common carotid artery, and then we divide into internal and external. So from the external, you have the superior thyroid artery, and superior thyroid artery here. Okay, this whole thing here is a superior thyroid artery. So a branch of the superior thyroid artery is the superior laryngeal artery. It will go pierce the thyrohyoid membrane along with the internal laryngeal nerve. Okay, so it's closely related to the internal laryngeal nerve. Another important branch of the another important innervation is the inferior laryngeal artery. So inferior laryngeal artery, you can see here. Okay, this here is your inferior thyroid. Okay, so a branch that goes into the larynx, this is known as the inferior laryngeal artery. Okay, so superior laryngeal artery from superior thyroid artery, and inferior laryngeal artery from inferior thyroid artery. The venous return is also the same. Superior laryngeal vein will drain into the superior thyroid vein. Inferior laryngeal vein will drain into the inferior thyroid vein. So the arterial supply and the venous return is the same. Okay. So far, so good. Any questions? No questions before we go into the clinical correlates?
Everything okay, doctor?
Everything okay, perfect. Okay, so we'll just be talking about a few clinical correlation that you will have to know. Okay, actually this is one I've mentioned earlier. So we have a injury to laryngeal nerves. It could be either injury to your recurrent laryngeal nerve or injury to the external laryngeal nerve. Okay, so recurrent laryngeal nerve, it's a lot of this in a laryngeal injury to laryngeal nerve occurs when you do surgery in the neck, okay, especially in the anterior part of the neck. The most common surgery in the anterior triangle of the neck is your thyroid surgery. So a lot of times you can actually injure the laryngeal nerve when you do a thyroidectomy, whether it be total or partial. Okay. So one injury is you can actually injure the external laryngeal nerve. Okay, this would cause external laryngeal nerve the motor supply to your cricothyroid muscle. Okay, remember the only muscle to not be supplied by the recurrent laryngeal nerve is your cricothyroid muscle. So if you injure the external branch, okay, you injure you paralyze the cricothyroid muscle, you have what is known as a monotonous voice. Remember, the cricothyroid muscle will tilt the thyroid cartilage forward and downwards. So this would enable the to tense or relax the vocal fold. So if you cannot tense or relax the vocal fold, you have what is known as a monotonous voice. You cannot have any up or down to your voice. Okay, it will be just a very monotonous voice if you injure the external branch of your superior laryngeal nerve. Okay. Um, the thing is, the external branch also is very near to your superior laryngeal artery. So if you look at this is your superior thyroid artery. Okay, this is superior laryngeal artery. Remember, these two branches will go to become the internal laryngeal, okay, as it pierces the thyroid membrane. But you can see this here is the external laryngeal nerve, and this here is the superior thyroid. So if they're here at this stage here, they're very closely related to each other. And in living human beings, you don't have like yellow for nerves and red for artery. Okay, so a lot of this, they're very small. It's very difficult to differentiate them. Sometimes you want to ligate one, you ligate the other, or sometimes you just nick the nerve, so you can also injure them. So if you want to cut the superior thyroid artery, sometimes you could injure the external laryngeal nerve, and that cause paralysis to your cricothyroid muscle, and that would not be able to move your thyroid cartilage, tilt your thyroid cartilage forward and downwards, and that would in turn enable you to lengthen or relax your vocal fold, and that will cause a monotonous voice. So this is the sign that you have to look for in the patient lah. Okay. So other than injuring the external laryngeal nerve when you want to ligate the superior thyroid artery, you can also injure the recurrent laryngeal nerve when you want to ligate the inferior thyroid artery. Okay, remember recurrent comes from the bottom, so it'll be more related to the inferior thyroid artery. So recurrent laryngeal nerve, it innervates all of the muscles of the intrinsic muscle, except your cricothyroid, of course. But the most important one is your posterior cricoarytenoid. Sorry, your posterior cricoarytenoid, correct. Okay, so posterior cricoarytenoid is the only one that would abduct the vocal fold. Okay, so if you injure one side, it's still okay. Okay, you just have what is known as hoarseness. Okay, because you can still breathe. But if you injure both recurrent laryngeal nerve, right, you can cause the patient to go into stridor, and the patient is not able to breathe. So you have a medical emergency on your hand. Okay, so that's the injury to the laryngeal nerve. Other than that, you can also aspirate foreign body. So sometimes if a patient chokes on food, okay, or in small children, whenever they pick up foreign objects and they eat it, even though they're not supposed to, the food can be stuck into the laryngeal vestibule. So laryngeal vestibule is above, remember the three parts of your laryngeal cavity. So laryngeal vestibule, infraglottic cavity, and the middle part. Okay, so sometimes food can be stuck in this area here. Okay, because this year you will find that you have your vestibular fold. Okay, so it will be located above the vestibular fold. So what you do is if the food part, the foreign object gets lodged in the laryngeal vestibule, okay, above the vestibular fold, what you can do is that you can do what is known as the Heimlich maneuver. Okay, basically you thrust the upper part of the abdomen. So when you do that, you would you would elevate the diaphragm, and you will compress the lungs, and it will help to expel the remaining air in the lungs, and hopefully it will be strong enough to remove the foreign object from the laryngeal vestibule. Okay, other than that is laryngoscopy, as I mentioned earlier. Okay, you can do either an indirect laryngoscopy with a mirror laryngoscope, or you can do a direct laryngoscopy with a fiber optic endoscopic instrument. Okay, so this is what you will see. Okay, if you can visualize, that's your epiglottis. So this is anterior, this is posterior. That's the epiglottis here. That's your corniculate cuneiform. That's your rima vestibuli. Down here would be the rima glottidis. Okay, and this is how you can visualize the larynx. Okay, other than that, you have laryngoscopy for intubation. Okay, so this is a laryngoscope that you use to intubate a patient. Okay, a patient who needs surgery or a patient who can't breathe on their own. Okay, you have to put an endotracheal tube inside. Okay, and how you do that is you can lift the your mouth, your tongue through the vallicula. So you put the blade of the laryngoscope in this area here. So when you pull this, okay, you pull this up, you can actually open up the larynx, and you can put the tube inside into the larynx and help the patient to breathe. Okay, so you put it in the vallicula. You can still remember from earlier on. Okay, lastly would be the trachea. So trachea would be connected to the cricoid cartilage. Okay, this whole thing is your larynx. Underneath here is all your trachea. So from inferior part of your larynx, which is your cricoid cartilage, all the way to the as it branch into two. Okay, your primary and your left and right primary bronchus. So all of this is the trachea. Okay. So the trachea is made up of your tracheal cartilage. So these are all your first tracheal ring, second tracheal ring. Okay, but remember trachea, they're not really full rings. Okay, they're actually C-shaped, and then there's going to be connected by a muscle at the end there. Okay, and inferiorly, before it bifurcates into your left and right primary bronchus, this in this region here is known as your carina. Okay, C-A-R-I-N-A, carina. And the division where this occurs, if you remember my mediastinum lecture, is at um, the transverse plane between the sternal angle, okay, to the IV disc between T4 and T5. Okay. All right. What else is known is important for the trachea? This one we talked about just now. Okay, certain correlations that you probably should have a little bit of uh, uh, little bit of light that we shed on. Okay, so the trachea here, right, anteriorly you have this. You can see here, this is your thyroid gland. I'm sure you all are familiar with it. Okay, you have a left lobe, you have a right lobe, and then connecting between them is the isthmus of the thyroid. So anteriorly here, you have a lot of the thyroid isthmus, and then also the inferior thyroid veins, okay, that drains inferiorly on the trachea itself. So these are the structures that covers the trachea anteriorly. Okay, and then lateral here you have quite important vessels. Okay, you have your common carotid here, as well as the lobes, and then posteriorly is your recurrent laryngeal nerve and the esophagus that's related to the trachea. Okay, so trachea as it ends at the sternal angle, between the sternal angle and IVDs T45, it will divide into your bronchi. So you have a left primary bronchus and you have a right primary bronchus. Now, what's important about the bronchi is that they're not exactly the same. Okay, so the right primary bronchus here, as you can see, is actually wider. The caliber of the bronchus is wider. Okay, it is shorter and it has a more vertical root to it. Okay, so the right side is more vertical, the left side is more horizontal. Okay, this here the right side is shorter, the left side is longer, and the left one is narrower. Hi, and the left one here is narrower, and the right one here is wider. So all of these factors, all of this difference makes it easier for an aspirated foreign body to go. If it's small enough, it can pass through the larynx. Okay, the foreign body will more often than not be lodged on the right primary bronchus. Okay, because it's wider, shorter, and more vertical. So we have a patient who complains of aspiration, and sometimes you have like a painful pain in the chest. Okay, it can be because of aspiration of foreign body. But in this situation, the patient can still breathe because the left side here is still patent. The left side here can still allows for respiration. It might be slightly difficult to breathe and you can have some pain in the chest, but you can still live lah. But you need to take it out definitely. Okay, so I'm not going to touch so much on tracheal deviation because you've done that in this final lecture, which is just like 4 weeks ago. In tracheostomy, okay, sometimes if the patient has any upper airway obstruction or the patient has been intubated for a long time, you need to put a tube in through the trachea. You need to remember that the trachea has relations. Okay, the isthmus needs to be divided sometimes, and you also need to be very careful of the inferior thyroid veins whenever you do a tracheostomy. Okay, and as I mentioned, okay, foreign body aspiration, we've talked about that. Okay, so it will go in the right side because it's wider, shorter, and more vertical. Can you hear the laughter at the back? I'm sorry. Someone is having a good time. Right, I think that's all. 129, right on the dot. Any issues, any doubts that you have that needs to be clarified? Are you all okay?
Yeah, we're okay.
Okay, no problems, No questions? If you are all happy with that, oh yeah, Jonathan, attendance, I guess. You can fill up your attendance now. No questions? If you have no questions, I guess that's all. I see you tomorrow for Long Tempura. Don't forget to sign attendance. And what else I want to say? And for those who have not yet submitted their student information, I know most of you have submitted. Thank you very much for that. But for those who have yet to do so, please do so. And I'll see you tomorrow. Thank you very much. Yes, Jana, I will also send the slides, the PDF to the channel, team channel.
Thank you, Doctor.
Okay, see you tomorrow then.